Welcome to today's FIST Forum featuring Jamie Reed with the LGBT Courage Coalition. FIST, Feminists In Struggle, is a national female-only radical feminist network composed of individuals born female and affiliated female-only organizations. We do political education and other things. Welcome, everybody. We have a great speaker today, a really amazing, courageous woman, Jamie Reed, who we all admire very much. She is a whistleblower from a gender clinic, so-called, in the state of Missouri. And I'm sure she'll tell us some about that, as well as other things she has to share today. And she's a co-founder of the LGBT Courage Coalition, which is an advocacy group of lesbian, gay, bi, and trans folks who are speaking out against what's been going on in Genderland. So without further ado, I'll turn this over to you, Jamie.
Thank you so much for having me today. I am honored to speak with you all. I'm a little bit nervous now that I know that Bev is here from the UK. I'm actually wearing my Turf Island shirt that I got over at the LGBT Alliance conference. So I guess a little shout out to the UK. So I'm going to go over my brief agenda and then I will launch right in. So what I'm going to do today is go over a brief history of myself, kind of where I came from, the history of how this started. I want to give you some information around puberty blockers, around cross-sex hormones, and then surgeries. Then I want to bring us kind of up to date what's going on currently, what we're seeing globally around the world, and then where I hope or possibly predict some of this to be going. What I really have as a goal is that you kind of walk away feeling empowered and really educated around this actual kind of medicine. I think there is an idea that some people think that this is super complicated and don't weigh in because this medicine seems really, really hard. I understand that. At the same time, there is some real simplicity to this. No one can change their sex. Kids should not be told that they can change their sex. And so in some ways, it's great to be educated. On some ways too, it's great to just go right back to the basics. Nobody can change their sex. Kids should never be told that they can. None of this is good, accurate, scientifically supported medical care. So a little bit about my own background. I live in St. Louis, Missouri. I have a bachelor's degree in cultural anthropology and a master's of science in clinical research management. I worked at a Planned Parenthood directly out of my undergrad. I managed a Planned Parenthood for close to 5 years. I have 2 biological kids and I have 3 adopted kids. I went on to work as a case manager in HIV for a long time. That is how I got into working in a pediatric gender center. So in the HIV world, I was seeing more and more patients who are HIV positive, but also trans identified, primarily men who are identifying as women. And I started to really get into trying to find ways to best serve them. And that is how I got brought over to the pediatric gender clinic. I was seen as one of the HIV case managers that was essentially kind of seen as an expert in the gender world. I worked in a pediatric gender center for close to 5 years in St. Louis, Missouri at Washington University School of Medicine. This concept of pediatrically transitioning kids in Europe, primarily in the Netherlands. This was called the Dutch protocol. So a small number of clinicians who were working with transsexual, trans-identified adults were essentially looking at them to see how well they were doing and found that they weren't doing very well. So these would be adults who had medically transitioned. They were still experiencing high rates of depression, anxiety. They were not socially functioning very well. They weren't in the workplace. They were not doing well in relationships. And so this clinician's concept or idea was maybe In part, it's because they don't pass. So again, this was back then primarily men who are identifying as women who were not passing in society. They came up with this idea to halt or to stop puberty and then go on to use cross-sex hormones and then surgery in this protocol that they referred to as the Dutch protocol. The very first research study that they did involved 70 young people. Of the 70, 68 were same-sex attracted. It is essentially considered that the first kid that was put on this pathway was a young lesbian, a young woman who was in a same-sex relationship and wanted to be in that relationship and was medically transitioned to appear male. There are tons of really good podcasts and conversations about how this Dutch protocol, all of their research is pretty flawed and didn't end up showing what they wanted. But essentially, this idea then caught on and then started to be reproduced. When trans people, especially online, will say things like trans people have been around forever, we've been here for millennia, what they are kind of indicating is that there have always been or have been long histories of individuals who have felt distress or discomfort within their biological sex. There's no disagreement to that. What has not been around forever is this idea that we were going to use medicines to try to let that person appear like the opposite sex. The early transsexuals were much more interested in surgery, and these protocols were much, much more about surgeries. A lot of these cross-sex hormones, I sometimes will say wrong sex hormones, were created not millennia. This is newer stuff. So sometimes when you hear this has been around for millennia, the use of wrong sex hormones in humans has not been around that long. The earliest transsexuals were actually seeking surgical interventions. The Dutch protocol jumped. It then rolled out in the UK. The UK started another clinical research study, and their results were essentially buried. They did not go to publish them. They could not reproduce some of what the Dutch saw as positive outcomes. Essentially, what they saw was kind of a wash, that the kids who went in doing okay were still kind of doing okay. The kids that came in not doing okay were still not doing okay. And yet, in the UK, they took that research study and they rolled it out into what is referred to as standard of care. So my background is in clinical research. Standard of care is usually not what's considered the baseline for everybody until it's been studied extensively with a lot of really good results. So we then see this jump again. So we see this now in the United States. Dr. Norman Spack and a psychologist, Dr. Erica Anderson comes in later, but Dr. Laura Edwards Leeper actually go to the Netherlands and they learn this protocol and they bring it back to the United States. So when it is started in the United States, it was not started as clinical research. It is my belief that it was clinical research and should have been clinical research when it was started in Boston. Instead, it was rolled out as standard of care, and Norman Spack and Laura Edwards Leeper started to transition kids in Boston. From there, it spread like wildfire across the United States. There are a lot of really interesting, good early papers that Laura Edwards Leeper puts out, that Norman Spack kind of talks about, where they also essentially recognize that they don't know if these are actually gay young people. They have no real ability to diagnostically determine which of these young people would grow up to be gays or lesbians, or who would grow up to continue to have sex-based distress around their bodies. They kind of don't care. They just transition all the kids anyway. I get a little bit of slack. I'm not trying to leave out Canada, Australia, or the rest of Europe. we see this same protocol spreading across those nations as well. And some of the countries right now that are so like neck deep in trans really are Canada, Australia, New Zealand, some of the other European countries. When I think about where we're at in fighting this, we see Europe, the UK, the US, Canada, Australia. A lot of these are English speaking, kind of white countries that really picked up this protocol and have really run with it. There's some things about these countries that don't have in common. We don't have in common the same kind of healthcare system that the UK or Canada has. We don't have nationalized healthcare. So when I talk later about where this is going and how we get out of this, it's going to look very different for these countries. But just know that this is a really driven, primarily issue across these English speaking countries. South Africa jumps in a little bit too. So I started working in a pediatric gender center in 2017, 2018. At this point, I'm in the Midwest. So this protocol has been spread all across the United States, and we see this concept of the trans child really well embraced across the US. When I started in the center, my role was that of a case manager and a clinical research coordinator. So I was primarily tasked with making the social work determinations of who we would see. I would do intensive intake. It would take about an hour with a new presenting patient, primarily with their parents. If you know anything about the Tavistock in the UK, one of the other whistleblowers, Anna Hutchinson, and I essentially had a very similar job. We both touched all of the brand new referrals that were coming to the centers. When I started, the new intakes referrals were about 4 new patients a month. A high month would be 10. And those kids that were presenting to the center were primarily boys. They were primarily prepubertal. So boys experience puberty later than girls do, but they were prepubertal and they were feminine. So they were presenting as kind of feminine, sissy boys, sometimes they're called. And oftentimes their parents was calling the center to see if we could see their kid, because back in 2017, 2018, there was still this concept kind of that the sissy boys struggled and that they had a hard time, the parents and the families had a hard time kind of dealing with these boys. By the time I left the center, I was having 50 to 70 new intakes a month. They were primarily girls. They were primarily post-pubertal. So think 15, 16. If you think back to when you had your first period, these girls were probably having first periods between 11 and 13. By 15 and 16, they already had been bleeding for a couple of years. They already had all of their breast development. But what had changed is we saw that we refer to this as a cohort. The cohort presenting had completely shifted from boys to girls, from prepubertal to postpubertal. And the other thing that really shifted was that these kids were not mentally okay. So those prepubertal boys were often sissy boys, they were feminine, but they weren't really struggling with huge amounts of mental health issues. The shift that we saw with these girls is that these were girls, postpubertal, and they had a litany of mental health concerns. Depression, anxiety, they were self-harming, they had disordered eating. Some of them already had bipolar disorder diagnoses. Some of them were self-diagnosing as having multiple personalities. And the other thing we saw a lot of is these other social contagions. So I think a lot of us, I'm in my mid-40s, remember kind of the anorexia and the bulimia, and we saw social contagions in young women years back. The other social contagions we were seeing in these young women was not just that they were trans identified, but they were presenting with things like TikTok tics. So this is a concept where they are highly engaged online. They are seeing other people, other social media influencers with tics, like tic disorder, with seizure disorders. They would mirror or present basically copying the things that they were seeing on TikTok. I had two patients who believed that they were blind, both young women. When we sent them to see the eye doctors came back and said they actually can see just fine. But these were girls that had really high mental health needs. They were not well. They were not functioning well, and they were doing a lot of concerning self-harming behaviors, not going to school, really in distress. What was interesting is that the same kind of cohort shift that I saw in my center has been now documented and been seen in a lot of other centers. So again, one of the things you're going to get pushback if you talk about this or talk online is when I say there was a social contagion, people will say, prove it. Well, when we look at the data, when we look at the presenting cohort from Tavistock, from even Canada's centers, from Australian centers, we see this exact same shift has occurred. The age has changed, the sex of the presenting kids has changed, and the mental health has changed. So the whole cohort kind of shifted in the exact same way. The things that we did in the center that I worked with were essentially 3 or 4 folds. You could think of it as 3 medical interventions, one that was considered not a medical intervention, but now we think really is. So I'll start with puberty blockers, then I'll go into the wrong sex or cross-sex hormones surgery, and that 4th thing is actually social transition. So I'm going to just talk briefly about social transition first, and then we'll go into the medicine. So a long time ago, when parents had kids that they thought sissy girls, tomboys, really masculine girls, really feminine boys, they would go first to a doctor and they would ask them, what do I do with my kid? So originally, it was almost always a clinician, a psychologist, a psychiatrist, who would tell the parents either to socially transition their kid or not to. And for a really long time, the psychologists and psychiatrists would tell parents, do not socially transition your kid, because that data used to show that if we let these kids kind of be long enough, they're going to desist. So the word is basically they would become more aligned with their sex. They maybe wouldn't present as tomboyish girls or as feminine boys, kind of that social pressure that young gays and lesbians feel when we go into puberty. So there's some of that we would see shift. Now, currently, almost every single kid that presents at a gender center globally has already been socially transitioned by their parents or school without any mental health provider's input. So that social transition would be that the child would have taken on a new name, pronouns will have changed, and dress and physical presentation. So that social transition can be as young as 2, 3, where parents will now either tell their child or allow their child, when you're 2, it's a parent doing it, but would basically change the child's name, pronouns, and manner of presenting to the world. So a social transition could be a young boy, 3, 4, 5, whose name was Bob. Parents will now call them Bonnie in public, change their pronouns to she, her, hers, essentially tell the child sometimes we'll tell the child, yes, you're just a girl, or you're a trans girl, and will have made all of these changes without the input of mental health professionals. One of the criticisms that we push back against with the schools is when schools do this, they're doing this outside of the guidance of mental health care. And what we now know is doing this, especially to younger kids, will concretize or essentially make concrete that trans identity, which has long-term repercussions because many of these kids would have desisted and no longer held on to this if we would not have done the social transition. So I say that it's not medical, but it's not benign. So social transition is not a benign or neutral act. It is very much a change to a young person, and a young person who has no real guidance or ability to make these conceptual leaps on their own. Kids will go along, especially those younger kids. I've had my own toddlers ask me completely naively just say, wait, am I a she? Am I a her? Am I a girl or a boy? Because what they're doing is they're trying to actually formulate and understand how we base our sex in the world. I had a conversation with my 3-year-old 2 days ago. He kept calling me sir, and I kept telling him I'm a ma'am. So these kids are really malleable. And so this is why it is so dangerous to see these social transitions occurring. In the center that I worked in, we were also using medical interventions. So puberty blockers are the ones that are kind of often seen as the most harmful or the ones that are quickly banned. So we've seen a puberty blockade ban in the UK. Puberty blockers are essentially an endocrine disrupting medication. So when they're used for precocious puberty, so that's when a young child is going into puberty well before their peers, what that does is it will trigger to the brain, to the pituitary glands, to the entire hormonal axis, stop what you're doing, turn off. There are serious questions about the use of puberty blockers, even in children who are experiencing what's known as precocious puberty. And the age of pubertal onset, especially in young women, has been getting younger and younger and younger and younger. And we don't entirely know why. Some people hypothesize that there are more endocrine disruptors just in our environment through all of the hormones that are in our environment. Sometimes we see that obese girls will start puberty earlier. There's also indications that younger girls who've been sexually abused will go into puberty earlier. So there's a lot that we don't fully understand or know about what is going on that we're seeing puberty onset at 6, 7, 8, 9. We would give kids puberty blockers in my center if they reached us in time. So puberty happens in stages. They're called Tanner stages. And if a kid came to us before they started puberty and were trans-identified, we actually kind of saw that as an emergency. Those were the kids that I would be instructed to get into the center as fast as I possibly could. So we would try to intervene and stop puberty from progressing in kids. This matters the most for the boys. So puberty in boys has all of the changes that we all kind of, if you've ever seen a boy go through puberty, you see these really intense changes. Their height shoots up, their shoulders change, their Adam's apple develops, they start getting facial hair come in, their voice will drop. They will begin to look like a man. And the reason why trans activists care so much about puberty blockade in boys is because estrogen, progestin, and the feminizing hormones are just not that strong. So if we got a kid, a boy, who had already gone through puberty, our ability to make them pass or look to the world like a female was very challenging. If I got a girl who had already gone through puberty, we could give them testosterone and we could create a facsimile of a man that could better pass in society. So when you think about puberty blockers, a whole lot of this concept is about making young men be able to look like women. This is really an attack on the boys. Puberty blockers essentially arrest or stop pubertal development. And what this means in the boys is really detrimental. So if they got to us at 11 and they were at Tanner stage 1, 2, or 3, the Dutch protocol would say by Tanner stage 3, their testicles would not have dropped or fully formed to start producing sperm. Their penis would still be the size of that of a child's. And we would try to intervene then and stop their puberty from going on. So if I take a young boy and I stop their puberty then, I am, beyond a shadow of a doubt, going to interrupt their fertility process for the rest of their life. If their testicles never develop the pathways and the process in order to make sperm, they will never have that function later. And so again, if you hear people saying, oh, this is sterilizing, and other people push back and say, oh, no, this doesn't affect fertility. It absolutely affects fertility, especially in the boys. Women are born with essentially all of the eggs that we will have access to for our fertility for a lifetime. Boys are not born with the pathway. They're not born with testicles just full of all the sperm they're ever going to use. They need to actually develop that. And puberty blockers stop that development right at that crucial time. The other thing that puberty blockers stop or arrest the development of in boys is their sexual function. So if their penis is never allowed to develop or grow, they are never creating the nerves, the pathways, all of the things that we know are important parts of sexual function later. So what is so detrimental about this protocol, and why I say this like a broken record, is that we are taking away the fertility and sexual function of children before they even know that these are elements that would be of such importance in their life. They are not able to consent for this because they don't even know what they're consenting to. We would sometimes use puberty blockers in the young girls, but again, part of the cohort problem is they were coming to us post-puberty. So there's really no point in giving a puberty blocker if you've already been through puberty. The other side note about puberty blockers, people will talk a lot about this is a money-making thing. It is and it isn't. Puberty blockers in the United States cost the equivalent of a brand new SUV. So $45,000, $50,000, $60,000 for a puberty blocker. You could have it implanted as a small rod in the arm. That would be a $50,000, $60,000 implant. Insurance sometimes would cover this. Even with insurance coverage, parents were often having to pay the entirety of the year's deductible, sometimes having to put up $4,000, $5,000, $6,000 for the procedure. Puberty blockers also are used in those young men well into adulthood. So again, estrogen, progesterone, those are just not that potent. And so we would keep their natural puberty suppressed for a really long time. So sometimes those kids would get 4, 5, 6 swap outs of those puberty blockers. So first one in at 11, and they're still getting them swapped out at 18, 19. So that's part of where we see a lot of this money. If you came to us early enough, we put you on a puberty blocker, we could then start you on wrong sex hormones. If you came to us before or after the time for the puberty blocker, we could still put you on wrong sex hormones. One of the ethical things that I saw as a huge problem very early on is that the WPATH protocol said that these kids should be 16 before we put them on wrong sex hormones. What I saw in my center is we would go all the way down to 13. So we were going outside of the WPATH guidelines. This is part of how in the US we started to break this entire protocol because our doctors are rogue and thought that they knew better. So we would put 13-year-olds on cross-sex hormones. So there's 2 different cross-sex hormones pathways. One thing I'm constantly amused by in like trans rights activism is they'll say things like, oh, sex isn't binary. There's not just two sexes, yet they always knew exactly which wrong sex hormones they were seeking. So they clearly always knew there's a binary sex. So we had the feminizing hormones and the masculinizing hormones. Feminizing hormones, again, not as potent, take way longer to get results. A lot of the trans women that you see will complain about this. We used a whole bunch of different options. So this is not just a one drug cocktail. This was a whole bunch of options. So estrogens, progesterones, a drug called spironolactone. Oftentimes trans rights activists will just call it Spiro. Or I hate that drug. And then we were also using a drug called bicalutamide. So the drugs like Spiro and bicalutamide are often used in older trans women. This is in some ways an amazingly interesting drug in the way that it was developed. It has a lot of side effects, but a lot of these drugs were created to treat cancers, specifically testicular cancers. So some cancers actually feed off of hormones. And some of our testicular cancers are fed or get more and more growth because they're being fed by testosterone. So what cancer doctors came up with is what's referred to in drug studies as lock and keys. So if you imagine that you have an old, not if you have a little dial code for your door, but if you actually still have a key, the key goes into the locking mechanism, it lines up, and it allows it to turn. So what they developed these drugs for was essentially a block so that the key couldn't go in. The key still existed, but it can't fit in the lock anymore. So bicalutamide and spironolactone are blocks. So the testosterone cannot go into the cells that testosterone is looking for, a testicle. Hey, give me more testosterone. But there are cells all over the body that are seeking hormones. So they developed this drug. The testosterone can't get in the lock. And the brain starts saying, uh-oh, I'm trying to open this door. I'm going to make more testosterone. So the brain will start kicking out more and more and more and more and more and more keys will try to fit in that lock. Well, what happened for the people with testicular cancer was fine, that the key couldn't get in. The cancer, the tumor wasn't being fed, but the body was building up this huge amount of testosterone, free floating testosterone. The first men that they gave these drugs to, it was helping their tumors shrink, but they were growing breasts, their their skin was softening, their beards were lessening. And the doctors were like, wait, what's going on? What is this side effect about? Well, essentially in the body, if I've got so much free floating testosterone, the body gets confused and it'll actually take all of that free floating testosterone and turn it into estrogen on its own. And so the feminization aspect happens for these men because we are blocking, the T turns into E, E then starts feminizing the body. So then the body starts developing breasts, skin softens. This is all of the things that the trans men wanted. And so the endocrinologist found this drug in oncology and they brought it over. And they said, oh, look, we can take the side effect from this drug and give it to men for what they are seeking, which is this high level of free floating estrogen. There are side effects to all of these drugs. Some of the drugs, and I think there's a question about Spiro, which we will totally get to. But one of the reasons why I hate Spiro, I hate some of these drugs, these side effects they're not good at all. So we see that they had urine incontinence, they had to go to the bathroom all the time, couldn't hold urine. But the other thing is that these cause a lot of brain fog and they cause a lot of mental health side effects. So people who are on like Spiro for a really long time will complain about the mental health side effects. Brain fog being probably one of the greatest examples. There are worries of early onset dementia because that testosterone's not just being blocked to the testicle, it's being blocked to the whole body, and a male needs testosterone. And so we see all of these ripple effects of the side effects. Our patient numbers were still smaller in the boys that we were feminizing, but we were using a lot of these drugs in kids completely off label with no research studies to back up doing this. So Spiro has had a number of studies primarily in adults. Bicalutamide had 0 to no studies in kids, to the point where it's actually written this should not be used in children. The center where I worked at used it all the time in kids. We knew that this was disrupting liver function and some of the other system functions. And so we were essentially just waiting to see how many kids we were going to poison and hurt their kidneys and their liver and these other systems. The cross-sex hormone to masculinize these girls is primarily testosterone. Testosterone is incredibly potent. It is so potent that if we prescribed testosterone as a gel, so think of hand lotion, I could prescribe you well, I don't prescribe. The doctors would prescribe. I would just tell you how to use it. You pump the hand lotion in. It's kind of a liquid testosterone. We wanted you to wear a glove, rub the testosterone on a place that was covered by a shirt, wait for it to dry completely, then put the shirt on, take the glove off inside out, tie it closed, because there's so much potency in that testosterone. We saw pets who were harmed if the gloves were left in the bathroom trash and the pet got tea on their face. We would have patients whose partner who was sleeping in the same bed would get testosterone exposure from it. So we were talking about changing sheets, sleeping on a towel, showering every time it was used. Testosterone is incredibly potent. Most girls who are on testosterone in the United States are using it as an injectable. So we're giving them needles, little vials of testosterone. They're going to draw it up. It's really viscous, so it's really thick, and it's kind of a weird oily substance. So they're going to draw it up, and they're going to either self-inject, or we were essentially seeing parents who are injecting their kids with testosterone. Testosterone is so potent that the effects are really quick. So one of the things that really troubles me about kids in gender medicine is that you cannot experiment with testosterone. This is not like, oh, I'm going to do this for a couple months and see. Immediately upon first kind of initiation of testosterone, the things that you would see is you would see the voice drop. Once the voice drops into that froggy kind of male range, it's never going to be able to come back up. It's permanent. The other thing that testosterone changes really quickly that a lot of people don't like to talk about is it actually will enlarge and grow the clitoris. So your clitoris will grow into what these kids were referring to as microphalluses, or their mini penises. The clitoris will grow, extend out, and to the point where I had a number of patients who were complaining of chafing, that they could no longer wear blue jeans, that their clitoris was extending outside of their vulva and was super sensitive and really painful. Very quickly, you see that change. The slower changes to testosterone, beards will develop, fat will move around. So women hold fat in their hips, thighs, breasts. That will shift into the stomach area. Abdominal fat is a less healthy area to hold fat. So we would see all of the compounding conflict when we see fat moving into the abdomen. The other things that testosterone will do, not as quickly, but over the long term, is you will see potential male pattern baldness. So especially if that genetically is in your family, these young girls would be losing their hairline would be receding, and then you would start seeing vaginal atrophy. So our vagina actually needs all of the hormones that our bodies produce. When we see women go through menopause, that's part of why we see vaginal atrophy, dryness, itching, issues with vagina health in menopause. It's because they need those hormones. So we would see young girls essentially experiencing the vaginal atrophy of somebody in menopause, or even worse than menopause. Vaginas that were easily friable. So that's a word we would use with tissues that could easily be torn open or injured. Oftentimes, we actually would have to add an estrogen cream to a 14-year-old we put on testosterone because we were decimating their vaginal tissues, to the point where we did send a few patients into emergency surgery. We had one young woman who had her first vaginal intercourse experience. She called the nurse. The nurse and I shared an office. She said, "I'm bleeding heavily. What should I do?" We told her, "Put a pad on and call us back if you've bled through the pad within an hour." She called us back within 20 minutes. She said, "I've bled completely through the pad. I've bled through my underwear. I've bled through my blue jeans. I've bled through the towel that I have wrapped around my waist, and I have now soaked the comforter on her bed." She was in an emergency situation. We sent her immediately to the emergency room, where they took her into surgery, and they found that her vaginal canal had been completely torn open because the tissues were so friable, so easily torn, that she ended up having to have emergency surgery to repair her vaginal canal. Side ethical dilemma, I tried to tell the hospital that that needed to be reported as a serious adverse event, and I was told by the doctors that I worked with that that is not an adverse event because it is a known and expected outcome of giving a young woman testosterone. Completely absurd. We did have patients who underwent surgery. Every time I hear activists say no young person has had surgery, first of all, that's completely and totally untrue. Young people in this country have had surgical interventions. There are two instances that are easily able to be pointed out in our country. Jazz Jennings underwent a vaginoplasty at the age of 17. It was recorded and aired on television, so we know that young people have had surgeries under the age of 18. I've also seen a hearing here in the United States where Chloe Cole was at a table sitting next to someone who said nobody in this country has had surgical interventions, and Chloe Cole rightly stated, "I had my breast removed as a minor." So there's a lot of arguments over this. There's just factual reality, and factual reality is children have had surgical procedures in this country. We had a huge number of patients who had top surgery. It's probably the most common surgical intervention that's given in this country to minors. Top surgery is a way to describe a bilateral mastectomy, where essentially all of the tissue is removed from the chest. It is then surgically reconstructed. It used to be reconstructed to masculinize the chest. So they would move the nipples. They would try to create a masculinized chest. If you're on any social media at all, you've seen just how egregious these doctors have become. There are patients now who have massive and horrifying surgical scars that just stretch straight across the body. They're doing surgeries now with no nipple reconstruction. The level of atrocity I've seen in some of these they're essentially maiming kids is what some of these surgeons are doing. We also have seen minors undergo what is referred to as bottom surgery. So in the girls, this is either the creation, or it can be a metoidioplasty or a phalloplasty or some variation in between. Essentially, sometimes there'll be surgery. If you think back to that microphallus, the clitoris that was growing, they will sometimes just do surgery to release the clitoral hood so that that growth can protrude more like a micropenis. Sometimes they will move the urethra through that microphallus to allow women to try to stand to pee, which is sometimes what people are seeking. And then one of the most challenging and kind of horrifying procedures that is done is a phalloplasty, where they're utilizing either forearm skin or skin from the upper thigh to create a poor reproduction of a phallus, which is then attached to the body. They move the urethra through it. There are so many bad outcomes to these surgeries, strictures, urinary incontinence, lifelong pain. And then it's a multi-staged surgery that sometimes will also require, if you want the penis to do something, then they also have to have a surgery later to either implant a surgical rod that is movable and bendable so that they can stimulate, pretend like it's erect. The other way to do that is instead of the rod, there is an implant device that has a bulb that is squeezed in the fake testicles that then inflates the phallus into an erect position. This is a surgery that has very poor outcomes. And then for the boys or the men, it's often a vaginoplasty. Vaginoplasty also has very poor outcomes. It used to be that they were inverting the penile tissue, so they would castrate them, remove the penis tissue, and then try to create a neo-vagina out of that tissue. Because so many kids have been puberty blocked now, there's oftentimes not enough tissue to even create the vaginal canal. So now they're moving into using parts of the colon. In the very first research study that came out of the Netherlands, one of the patients out of that 70 cohort died because they did not have enough penile tissue to create a neovagina. So they used part of their colon, and that part of the colon then created a septic situation, and they developed an intense infection and they died. So part of what is a struggle, just from a clinical research perspective, is how did a protocol that had a death within only 70 patients from its primary outcome ever be considered a good enough protocol to even consider trying it elsewhere? Surgical procedures in the US are sometimes the first thing that we can see be banned. And sometimes the first thing, if you're talking to somebody who's kind of on the fence or doesn't know what they think about this, sometimes it's the first thing that they'll agree with. They'll say, oh, no kids should have surgery. These surgeries, though, are not a positive outcome at any age. And sometimes the detransitioners, especially the boys that I've worked with that have the highest rates of regret and really mourning, is that they've had surgical castration procedures at 18, 19, 20, 21. It is a lifetime of suffering, oftentimes, over that procedure. So in 2022 into 2023, I became essentially one of the only or first whistleblowers out of a clinic, out of a center here in the United States. Some of the stories I shared with you today were part of my affidavit, which I filed with the Missouri Attorney General. In the center, for a long time, there were intense arguments, debates, ethical debates between myself, the nurse, our psychiatrist would oftentimes be on one side, and then the endocrinologist, the adolescent medicine doctor, and the psychologists on the other side debating these treatments. When I first started to grow concerned over these, I honestly just thought we needed to follow the protocols better and that we were being reckless with the protocols and transitioning too many kids. It took close to my 5 years to really begin to recognize that there was no way this protocol could ever be carried out in an ethical manner, and that even the kids who we made look and pass were never aligning internally with their external, because what we are essentially doing is asking children to grow up and live within a lie. And what I saw out of the kids who were supposed to be the successes, when parents will say, my kid is happier, when people will say, this is a success story, there always was some element of mental health distress because there is an inability with that cognitive dissonance for a young person to grow up within a lie, and a lie that is representative by their physical reality in the world. After I blew the whistle in Missouri, Missouri quickly went on to pass a ban, and that ban was against puberty blockers, cross-sex hormones, and surgeries in the state. Where we're at right now in the United States is we have close to 26 states that have some kind of a ban. Not all of those bans are being enforced. We are waiting on a Supreme Court hearing called Skrmetti to see if it is going to be upheld that Tennessee's ban is going to be allowed to stay in effect. We are pretty confident that the United States Supreme Court is going to rule in our favor on that. And now we've also had a week, one of the busiest weeks of my life since this has all started, where we're seeing executive orders coming out of Washington that are going to start dismantling the pieces that the federal government that can touch, to start dismantling some of this from some of the other states where this is still in effect. Where I hope that this will go will be a national ban on any puberty blockers, wrong sex hormones, surgeries in any minor. And what I would also like to see in any adult populations is the complete reversal of any insurance coverage, Medicaid, Medicare, TRICARE. No insurance should be covering any of these procedures in adults. And we also seriously need to have ethical considerations around whether or not adults who do have the right to self-harm, adults have the rights to do a lot of things kids cannot do, but the ethical question becomes, do doctors have the right to assist in self-harming behaviors? And so I think that's going to be our next ethical dilemma to look at here in the United States. Okay, that goes through my list of agenda. Who wants to manage the Q&A?
Okay, well, thank you so much, Jamie. That was amazing and quite difficult to hear at times as a lesbian who shudders to think of what would have happened if I had been born in this day and age. Before I open it up to questions, I want to remind people, please raise your hand and I will do my best to choose you in order. And I'm going to take advantage of my spot here to just ask you a couple of questions. Why do you think this has been allowed to happen? If you have any opinion on that.
I think at the root of this is some real distress in our society around homosexuals and sex conformity. So I believe that a lot of this stems from homophobia, both internalized and external. Many of the clinicians that work in centers like this are gay and lesbians, and so we see elements of internalized homophobia that is still coming into play. But then there is this other strong element that we as a society have strong aversions to sex conformity. So I think so many of us, especially if we're parents or aunts or uncles or grandparents, we can easily see when kids are sex nonconforming. The sissy boys, the tomboy girls, they exist, they're real. Sex nonconformity exists almost universally. But how we deal with that as a society has long been in flux. And so a lot of this stems from not understanding how to embrace sex conformity within our societies in a way that is both healthy for all involved while still recognizing that we do have to have some elements of sex conformity in society.
Okay, that's a great answer. Let me see, let me switch to the gallery view here so I can see who has their hand up, if anyone does. And please keep your questions and comments brief if you can. Thank you. Do I have any hands up? Or I have lots of questions if you guys don't.
I can take a question from the chat too. So there was a question about spironolactone. My elderly father was put on it, plus many other strong meds for extremely high blood pressure, but the side effects were pretty rough. So a cardiologist determined his heart was okay enough to go off the worst one, and they chose to go off Spiro. Yeah, okay. So what are the other side effects are common in the young, and how does that change over time? So Spiro, we did not use Spiro a lot. It's still used a lot in adults. Really, the worst side effects. If you think about it, what all of these either feminizing or masculinizing drugs are doing is they're essentially intentionally disrupting an endocrine system that is in homeostasis. And so I struggle with the word poison, but we are essentially breaking an endocrine system that is trying to work constantly to balance out that system within the body. And so the side effects to these drugs is essentially every single part of the body that the endocrine system touches. So in the girls, cholesterol will shoot up, prediabetes, they'll produce way too many red blood cells, fat redistributing, BMI will go higher. A lot of social emotional changes that a lot of trans people sometimes will still deny, but anger, sleep, like all of the things our hormones affect are affected when we intentionally break a functioning endocrine system. Okay.
Okay, so the first hand is Fran. Fran, go ahead. You're muted. Fran, can you unmute yourself? Otherwise, I'll go to the next person.
Yeah, I just unmuted myself. Can I be
Okay.
heard?
Yes.
Yes.
Okay, good. All right. This is a very well put together. I mean, coming out of your experience, I really appreciate all of the detail, and it is totally damning of all of these procedures. And I have been on that side for a long, long time. However, some of what's happening is also putting some feminists in conflict about how this new legislation, which seems to many of us to be positive in that it would get rid of these treatments, but also is very much trying in all of its philosophy to take away all of women's rights. And that's spelled out in Project 2025, which is, you know, going on apace, take away workplace anti-discrimination law, tax people who don't have children. Basically, it's a very retrogressive, put women back in traditional roles position. So some people are saying, and myself among them, why are they giving us this gift? How will this be used against women and women's liberation, which is far from achieved? And there's some indication that a lot of right-wing men are saying, well, we've got to get rid of all sex segregated spaces. This is about women, women's spaces being invaded by men. And this is really great because we'll get women out of men's spaces, which is very problematic because, of course, women have had to fight to get into men's spaces in order to be part of public life. I could go on and on. There's a kind of like, is this a wolf in sheep's clothing, which I've heard many women say. And I must add one more point. The Skrmetti decision, because it lumps sex and gender identity and basically says that both should have, this is legal and it's a little detailed, I can't get into all of it, but both, they should have intermediate scrutiny, which is not the highest level, right, of, enforcing anti-sex discrimination, right, basically may have the outcome, probably will, of making strict scrutiny not available to women, which basically means you can't have the Equal Rights Amendment, which we desperately need. So I see by your nodding that you are aware of all this. So we are really in a pickle here, because it's like, maybe it's the right thing, but it's for so much the wrong reasons and in the wrong directions that it does endanger women and feminist goals. So that's what I wanted to say. How do we navigate this? A lot of people are asking that.
Yeah. Excellent questions. The first thing I'm going to say is that there are so many of these things that I also am not an expert on. So I'm not a lawyer. I'm not an expert on, you know, constitutional law. The elements here that I think we're trying to navigate right now is step one is these are executive orders. So executive orders, often they will expire in 4 years. They will not remain as constitutional or congressional law. And so I think that what the executive orders are giving us in some ways, I want to try to see this as the gift that we can then work through. So we let the executive orders do the things that they're going to do. I appreciate some elements of that, just putting sex, rights, or at least sex recognition back into law. But where we need to then start working with groups like your own is have those conversations about what this looks like if we're actually going to see this turn into federal congressional law. The other element at the Supreme Court level that I don't know if Bev and I don't even know if we have the same position on this. Bev sometimes knows more about American law than I do, is the question still that were arisen over the Bostock ruling. And yes, where do we see things like protections in the workplace against how sex is lived and how sex is presented and what clothing and all of these things are really kind of up in the air right now. My primary focus is, I kind of see this as the triage from an ambulance just pulling up. So right now we have kids that are in the middle of a horrific accident that we need to get some tourniquets on. Tourniquets are not good long-term solutions. And so we look at the executive orders for what they are, potentially pull out the things that are the best concepts. Some of the language in there is not great ideas either. And then we think about what we actually want to present in our society as the right way forward. I don't have the answers on all the bathroom questions and how sex is presented and how we navigate all of those as society. But for that kind of right now, that emergent feeling, I like to think executive orders are temporary. This is a tourniquet that's been thrown on. We now can try to navigate what happens in the next steps as state law and congressional law. And there are a lot of state laws being proposed right now, like legislative. It is like hardcore right now. My next call in an hour is on legislative strategy across like 6 different states. There are bills that are mirroring that executive order on sex and gender that are being proposed in states. So if you don't know what's going on in your own state, I would totally just go to your state's House and Senate page and start digging through what's being proposed around sex and gender. Get involved in those, because that's where this is going to start continuing to be hashed out.
Thank you, Jamie. Yeah, I know your expertise is more in the medical arena,
Yes.
but I know you're in the middle of everything too.
Yes.
So thank you
Yes.
for that nuanced answer. And the next question is from Beth.
Yes, briefly, I had 2 issues. One was I was just wondering what your professional background is, and also I know you mentioned this a lot. I've heard about it a lot. The Dutch protocol. What exactly is it?
Perfect. Okay. My professional background. So I have a bachelor's degree in cultural anthropology. I studied abroad a lot and worked with homeless street kids in West Africa and did a lot of ethnographic writing around street kids. I then pivoted into clinical research, but my master's of science is in clinical research management. So that means my training is actually in writing clinical research protocols and then being the clinical research coordinator to carry those out. So oftentimes my actual job in life would be to work directly with a principal investigator, so work directly with a doctor to craft a clinical research protocol and then make sure it's carried it out. A lot of my training is in ethical standards around clinical research, and a lot of it is also in like historical, ethical, where we went really, really wrong in clinical research in the past. So that's kind of my background. I'm not a social worker. I was hired as a social worker in a lot of roles. And I've played that kind of role, but I primarily am in clinical research. The Dutch protocol itself is this concept that you puberty blockade around Tanner stage 3. Then you proceed on to cross-sex hormones, usually around the age of 16, and then you proceed into surgical transition around the age of 18. And they saw this as kind of a 3-part system. They saw this as you do these in steps. The other weird part about the Dutch protocol that did not get carried over is they saw the period of pubertal blockade as part of the diagnostic like the diagnostics, not that it was the intervention itself. So they wanted to use puberty blockers as the time to think, which is why Hannah Barnes' book about Tavistock is called that. Their original protocol thought we're going to stop puberty to give these kids more time to think about what their gender actually is. What they didn't realize, but what shows out in the numbers, is once you start puberty blocking kids, you're also just concretizing the trans identity again. And pretty much 99% of those ever put on a puberty blocker will just go on to cross-sex hormones. So that's kind of the concept of what the Dutch protocol was.
Okay, let's jump to the chat. There's a couple of questions in there.
Okay, I can go through these. Did my clinic record detransitioners as detransitioners or record any doubts at all? That's 2 different questions. So we knew of some detransitioners who would come to us by record. If we knew and that they told us they're detransitioners, it would be in the chart. If you dug through and like look through my phone call notes or my clinical like notes from, but we did not have like a coding way to count them as detransitioners. The charts, like charts are their own nightmare in this. There's a lot of miscoding intentionally. There's a lot of ways that you can change the sex marker in a chart. There's a lot of mess around medical charts. So there's not a good way to actually use those as any way to like count detransitioners or desisters. Did your clinic use the fear of suicide to persuade parents who are questioning the treatment? Absolutely, 1000%. I sat in patient rooms hundreds of times where I saw the clinicians literally tell the parents, would you rather have a dead son or a living daughter? Or would you rather have a living daughter or a dead son? Saw it constantly all the time. And often the thing that I struggle with the most is we would actually say that phrase in front of the child themselves. So if the kid themselves was not already thinking of that, we actually planted that as a seed and essentially told them, here, you can use this against your parents. So it was completely unethical the way that that was used and continues to be used in centers. Part of that problem, though, is the doctor I saw use it the most, she had transitioned her own kid. She thought she had saved her own kid from suicide. So you see these overlapping ethical issues. Next one, as we move to codify these protections for children from medicalization for their gender distress, do you have any advice for providing alternatives? How can we ensure push for non-affirmative therapy or for gender distress, mental health? Okay. So there's a couple good organizations that are working on this. So one of the best one that I work with frequently is called Therapy First. Therapy First has a national network of therapists who absolutely provide non-affirmation related therapy. therapy that's grounded in sex as reality, but is very caring, very, very open-hearted therapists. They're great therapists. So I do see that we're starting to create the networks for alternative pathways. The other good kind of concept is there's an alternative school. So there's a therapeutic school run by Dr. Alex Capo in Upper New York. He was interviewed once on Gender Wider Lens. One of the alternatives that his school actually just utilizes is this concept that these are kids who are really just seeking adult guidance. And so when they intake a new patient, they just straight up say to the kid, primarily girls, in our school, we're going to take care of you. You're going to be afforded the best treatments available. We're going to make sure that you are heard, listened to, and cared for, but you are going to be referred to as your birth name and your biological sex. And what he has documented is that so many of these kids have just been waiting for a grown-up to take the reins and tell them, you're okay, we've got this. The grown-ups in the room are going to make sure you are taken care of, but we're not doing this anymore. And part of where all of this went wrong is that we have created this concept that children know better and children know best, and we've kind of let children take the reins. And so one of the alternative ways out is to develop some of these concepts that in schools, we're not doing this. We're not calling anybody new pronouns. We're not doing crazy, weird pronoun circles in schools anymore. We need adults to come back to the table and be in charge. And so hopefully we can see some of that occurring.
Okay, thanks. Carol, you have your hand up. You're muted. Carol, we can't hear you.
Okay, can you hear me now?
There you are, yes.
Okay. Yeah, a couple of comments. One, just quickly, we know that a lot of what has fueled this stuff, of course, is the big pharmaceuticals who are making billions of dollars off of it. But also, with regard to gender identity and, it getting conflated with sex, that's a serious problem for women and girls' rights. And it's why we're on the verge of losing the ERA, even if we were to get it published, because of this Skrmetti decision that was based on, they started it and Bostock conflating the two. And now on Skrmetti, if they do that, then the level of judicial scrutiny could be lowered down, not even to intermediate, but even to possibly rational basis, which would be disastrous for women and girls' rights and our separate spaces and sports and the invasion of, prison cells and so on. But the thing I wanted to ask you, Jamie, that is really important is when this was first conceived of, I remember when we interviewed you before in the Gasper group, the Green Alliance for Sex-Based Rights. Well, it was actually the Georgia Green Party. You mentioned the Nuremberg protocols. The fact that we're doing medical experimentation here, and it's the whole point of the Nuremberg trials was to establish some kind of guardrails with regard to, what kinds of medical procedures could be imposed on people because of human rights and so on. I wanted to ask you how they got around that, and if you could expound on that a little bit, I'd appreciate it. Thank you.
Yes. So Nuremberg, the declaration from Helsinki, and then there's one other international clinical research guideline. So how they got around this is a great question, and part of something that we should start thinking about in terms of what doctors are allowed to do. So it's kind of twofold. If you can declare something a standard of care, then you essentially pull it out of the realm of research and into what's considered the standard protocol. I have asked Laura Edwards Leeper directly to her face. I have asked her to explain to me how in Boston, her and Norman Spack made the decision that this was standard of care and not a clinical research guideline. She got very hesitant, said, I was not the lead clinician. You'll have to ask Dr. Norman Spack. What I would very much like to see is true investigations into how this jumped from clinical research protocol into standard of care. Same thing happened in the UK. UK was running a study. They buried the research and they jumped it and claimed it to be standard of care. This presents and shows a huge, huge ethical loophole problem in clinical research that needs to be seriously considered. The other issue with clinical ethics and clinical research ethics are there considered special patient populations. Those patient populations that you are not supposed to research on without much tighter guidelines include prisoners, include those who have mental handicaps, mental disabilities, mental reasons why they are not able to understand clinical research and what they're consenting to, and then children. And children have always been considered a special protected class and category. Part of the way that clinical research currently in the United States is protected still involves that the doctor has to make the decision and determination that what they're doing is research versus just treating standard of care. The other loophole that doctors have that we use all the time that maybe is a good thing, maybe is not, is doctors are allowed to use drugs outside of what they are approved for. So doctors can use drugs off-label constantly. They can prescribe you a drug. You've probably been prescribed a drug that's off-label use that was never tested for what they're prescribing it to you for. Kids are prescribed blood pressure medications to treat ADHD, totally off-label. They have not tested that and the outcomes of that. So this is huge. These are huge questions well outside of my pay grade. But what I think would be of ethical importance. The other thing is that we had captured institutions that laid down and played dead as trans walked all over the world. And one of those was medical ethics. One of those was clinical research, journalists, schools, you have it, you name it. Trans just walked all over everything. And I think if we really, once we get out of this mess, I hope to have enough years left in me to make sure we set up some better societal protections so something else like this can't walk all over again.
Thank you. That's a great answer. And I might add, for the past 30 years or so in the United States, corporations have been running the FDA. They have been running the government departments that are in charge of medical care. As we all know, the insurance companies too are not paying doctors very much. So perhaps they have incentive to find new ways, new forms of revenue. That's just my opinion. Okay, we have more questions in the chat, I think.
Okay, and then probably have about maybe 5-10 more minutes.
Okay.
Oh, hi, Bev. Okay. Therapy First sounds like a great organization, and in Massachusetts and other states, yes, there have been anti-conversion therapy laws. What's really interesting is a lot of these laws, the people who are supposed to look into them, really, they don't have much teeth behind them. And oftentimes the Therapy First therapists who have seen this challenged under that anti-conversion therapy have been able to successfully protect their license. It has happened in a few states, though, where some of these therapists have gone after it. I think more what those anti-conversion therapies laws have done is just kind of scare the good therapists away from working with kids of any kind that have anything to do with this. That's another huge thing that needs to be tackled. We need to get those anti-conversion therapy laws off the books, especially when they talk about just sex realism. It's another point where they conflated and they basically used the LGB to try to, you know, slide in trans. Bev, yes. So as far as Bev writes, as far as I understand, the executive order will block federal funding for institutions that continue to conduct these interventions. So this is primarily going to affect university hospitals and the bigger hospital systems that have huge budgets that absolutely rely on federal funding and grants, especially. The blue states that still allow pediatric sex trait modification interventions to happen, we're still going to see the smaller, more one-off clinicians still doing this. What's going to close is probably the larger centers that often had multidisciplinary teams. Not that they were functioning well, but that is what the shift is going to be. We still will need state by state laws to stop these in those states. I also still think we're going to need actual enforcement tools. It's great that the EO says this. We need actual enforcement, making sure the hospitals are actually stopping.
Okay, so we have just a few minutes left. Fran, if you could be brief with your follow-up. Fran, you still, okay, maybe you don't know you have your hand up. So Jamie, what would you, where would you send parents? Where would you advise parents to go who are confused or just maybe know in their gut that there's something wrong with all of this? Is there a place we can send them?
Yes. So we are in the middle of rebuilding our entire website and completely rebranding. We will be the Courage Coalition. I would love to say direct people to our website, should be up within a month's time. There are so many good resources out there. Therapy First, LGB Alliance in the UK, LGB Alliance in the US. I also know DIAG, SEGM, GenSpec has tried to kind of come over to the US a bit too. Honestly, I think if parents, there's also Partners for Ethical Care that is run, there's so many good resources out there right now. One of the things we're looking to do just on our own is to create better guides to kind of point not just parents, but gays, lesbians, concerned women like into kind of channel. There are so many people working on this right now that we really just need to find better ways to organize the people that we already have out there. There's so many options.
Okay, that's wonderful news. And it looks like we have Judy with the hand up.
Yes, thank you. Jamie, I know you probably already covered a lot of this already, but quickly, some of the most important things to mention to adults, the harms that are done to adults through medical transitioning and drugs. Thanks.
Yeah, this is something that we're pivoting into. The cohort of most concern right now, I actually think is the 18 to 24-year-old cohort. That's who we've seen some of the greatest numbers of just, these are still young people and they're jumping into this trans identification. For adults of all ages though, too, these are poorly outcomed and poorly researched longitudinally interventions. So I think the basic way that I conceptualize this is we are intentionally breaking a functioning endocrine system. We are intentionally mutilating and harming physical bodies. And the other element that we really have yet to explain well, even to adults, is that there are these different cohorts of the adults that seek to transition. A large cohort of those are gays and lesbians. And so from my perspective, we are still seeing the true and utter decimation of the lesbian population, particularly butch or masculine women are being pushed into this. And the long-term outcome is not only the degradation to physical health, but mental health is not helped for anyone to live within the cognitive dissonance of a lie. Sex cannot be changed for anyone. And the long-term outcome is that we would have much better success as society as to address the underlying homophobia that leads so many people as adults to medically transition, and to really give compassionate, thoughtful therapy to those who do this out of sexual paraphilias and out of misplaced or misguided sexual issues. It doesn't help anyone. And the other question I think we have the right to ask of a society is, what are the downstream societal harms to the entire concept of trans? Trans is broken. Law, schools, education, our sports systems, families, kids. And as a society, I think that the harms of trans as a concept outweigh any benefit a small cohort minority might receive or claim that they're receiving. So these are just going to be the bigger ethical questions that we need to figure out ways to have conversations around on a societal level. This is not about being transphobic towards individuals or wishing harm on individuals. This is asking, what does trans cost us as a society, and making a decision that as a society, it's too big of a cost and we're not going to bear that burden anymore.
Well, Jamie, thank
Thank
you
you.
so much for your time. This will be posted to YouTube. I urge everyone to send this video around. Send it to your representatives, especially if you live in a blue state. Send them the link. They need to be educated on what's going on here, because now that we have this executive order, I'm guessing it's going to create a lot of pushback to the order. And states are going to try to, protect the trans youth as they are misguided to do. Thank you so much, and we look forward to having you again once your website is redone and all your work is
Yes.
expanded even more. And we will linger on after Jamie goes. I know you have another Zoom to do,
I'm going to blow kisses to Bev.
and we'll turn off the recorder.
You all have an excellent meeting. Thank you so much for having me today.
Thanks again, Jamie.
Thank you.
Thank you, Jamie.
We'll stop the recording.